Thank you guys. Thanks, Cindy. Good morning. It's awesome to be here. So thanks to Carla and Anthony for having me. I'm going to talk about hip and knee replacements and try to focus on what I think you guys need to know, or I would like you to know about it. I'm not going to go a lot over knee arthritis because I think Dr. Feely did that, but I'll give a little bit of a reminder for those who weren't able to be here yesterday. I have no disclosures, but if you'd like to give me some, I'll be available later. So I'm going to talk about a little bit of the burden of disease of arthritis and the burden of disease of hip and knee replacement itself, and how that relates to the epidemiology of how many hip and knee replacements we do and what that means for surgery for these patients and revision surgery for these patients. I'll talk about the basics of hip and knee replacement and what we think about. And then I'm going to talk a little bit about the big changes over the last decade or so with hip and knee replacement that have changed what patients we treat, who we give joint replacement to, how we manage their pain, and how they recover from this, as well as some of the changes in DVT and PE prophylaxis, as well as risk reduction. Then at the end, I'm going to talk a little bit about some of the myths and questions that your patients ask you and ask us quite often. So first of all, I want to take this opportunity to say thank you. When I was going through medical school, I thought that primary care was the hardest job in medicine, which is why I chose the much easier job of being an orthopedic surgeon. You guys deal with a ton of stuff, and I don't know how you do it, and I really appreciate it. I think we all do. And you helped me treat Rose. So Rose is one of my first hip replacements. She's 79, and she came to me with walking pretty much with a walker and a wheelchair most of the time. And we replaced her hip, and she went back to doing what she loves to do, which is dancing the Macarena. And she's just adorable. But this is why I love this surgery. This is why I love replacing hips and knees, is because you really get to be a quality of life doctor. And I think for most of your patients with arthritis, at the end of the day, this can be a really good solution to their problem. And it can often be a permanent solution to their problem. And in very few places in medicine do we get to find a permanent solution to someone's problem. And as we all know, this is a big problem. Arthritis has a huge burden of disease in our country. It's the most common cause of disability in the US. About 0.25% of people have been told by a doctor that they have arthritis. And the last time the CDC tried to estimate the cost of this, back in 2003, it was 1.2% of our GDP, which is just an insane number when you consider how much money is spent on one disease. And concomitant to that is the dramatic rise in the utilization of hip and knee arthroplasty. So when this study was published in 2007, we were doing about 500,000 knee replacements and about 200,000 hip replacements in the US every year. And this was projected to rise to 3.5 million knee replacements every single year by 2030 and over 500,000 hip replacements every year by 2030. It's been 10 years since the study was published, and state registry data have actually borne this out to be very much true for the knee replacements, and we've actually exceeded this with hip replacements in terms of how many of these we are doing now in the United States every year. So there's a huge number of patients who are getting hip and knee replacements, which also means there's a huge number of patients who are living with these replacements. We're now in the tens of millions of patients in the US prevalence-wise who are living with a joint replacement. That also means that even though the complication rate for these overall is low and they fail at a very low rate, it does mean that numbers-wise, there are a lot of patients who end up needing surgery down the road to deal with a failed joint replacement or a worn-out joint replacement. So the causes of this increased utilization is intimately involved with the amount of arthritis that we have, certainly involved with our aging population and how much longer people are living in the baby boomer generation, but also because we're doing arthroplasty for younger patients. And this is both because of the improvements in technology that have allowed us to give arthroplasty to younger patients without as much of a fear of them wearing out. And it's a huge part of it is due to the obesity epidemic in our country. So patients who are obese, on average, get their joint replaced 10 years younger than a non-obese patient. And if you link obesity to the causes of arthritis and joint replacement, about 30% of all joint replacements in this country can be directly attributed to obesity. So this is a huge cause in the rise in utilization, and will only increase. And I'll talk a little bit about what this means in terms of the risks for these patients, because that changes as well. So just to recap from what Dr. Feely talked about yesterday, so arthritis, bottom line, is cartilage degeneration. So any sort of degeneration of the cartilage that leads to pain, limping, swelling of the joint, and eventually a loss of range of motion, as well as bony deformity. And that bony deformity comes from the reaction of the bone to the loss of cartilage. And that's why you get patients with bowed legs with knee arthritis or knock knees with knee arthritis. That's why you get patients who have hip contractures. All of these symptoms can be intermittent even though the arthritis doesn't change. And that's because it's not the cartilage degeneration itself that hurts, it's the inflammation that it causes, which is why the treatments aimed at decreasing the inflammation are the ones that are the most effective. And the causes, as we know, are standard sort of wear and tear osteoarthritis. Now, the literature seems to start to support that there is some genetic basis to osteoarthritis, however, not a lot. The strongest linkage, again, to osteoarthritis, wear and tear arthritis, really is obesity. Inflammatory arthritis is still very reasonably prevalent, although we are replacing joints much less often for patients with inflammatory arthritis in this day and age with the newer medications, which is actually just wonderful for these patients. Trauma and fracture patients are an increasing population that we see. So again, with the aging population, we're getting a lot of hip fractures. I think next year there are going to be about 1 million hip fractures in this country. Now, for those patients we fix who then go on to heal, about 30% of them end up needing a joint replacement down the road. Also, with sports injuries and knee problems becoming ever more prevalent, we're seeing a lot of patients who had an ACL tear, meniscus pathology, some kind of knee injury in their 20s and 30s who are getting early arthritis in their 40s and 50s from knee trauma. Osteonecrosis, which I'll talk about a little bit in more detail, is sort of a lack of oxygen to the bone. That's just the definition. It's a little bit more rare, but we do see it particularly in the hip, not as much in the knee. And then we also see a lot of childhood development disease in the hip, not as much in the knee. We see some blounce and things like that we need to correct, but developmental hip dysplasia is something we treat very commonly. So the diagnosis of arthritis, as we know, is largely symptomatic, but for us in arthroplasty, it's really, a lot of it's about the symptoms correlating with the radiographs. So when you get x-rays, and I think as Dr. Feely talked about yesterday, as a reminder, please get them weight-bearing. On this x-ray, as you can see on the, I guess your left, this is the same patient. This is a non-weight-bearing x-ray, and this is a weight-bearing x-ray. And here you would categorize this as, at best, mild arthritis, and here is moderate to severe arthritis. So the weight-bearing x-ray can really show you the fact that the cartilage is gone. So please get weight-bearing films. MRIs are rarely necessary for us as arthroplasty surgeons. They're expensive. They're unfortunately overutilized because patients tend to sort of force all of us collectively to get them. And they actually create a number of problems. They create a lot of confusion for patients who are now, with access to their own medical records, reading their radiology reports and saying, well, I have a meniscus tear. Isn't that the cause of the pain? And so that can create a lot of confusion for patients and some issues in treating them. The one case where MRI really is indicated, and I'll talk about that again, is osteonecrosis. But if they already have arthritis on the x-ray, it's just an MRI just isn't worth it. And it's not going to add anything to what we tell them and what treatments we offer. So this is what knee arthritis looks like on an x-ray. As we saw, this is someone's knee without much arthritis, and this is severe arthritis. You see, subchondral sclerosis, osteopenia, subchondral cysts, osteophytes, and particularly joint space narrowing. And then when you get inside the knee surgically, it's exactly what it looks like. It looks painful. They have lots of bone spurs, lots of synovitis. The knee just looks horrible and painful. So it clinically correlates with the x-ray very nicely. It's one of those diseases that works really well that way. And same thing with hip arthritis. Again, you get joint space narrowing, large bone spurs, a lot of deformity of the bone around the joint, and when we see it inside the hip, it's the same thing. Inflammatory arthritis is a little bit different. So for inflammatory arthritis, instead of the large bone spurs, what you really get is some subchondral sclerosis, which behind that is actually very osteopenic bones. This bone is really bad. And then you get usually concentric joint space narrowing as opposed to eccentric joint space narrowing. And that's because this disease eats away the cartilage in a sort of even distribution as opposed to a weight-bearing distribution. Now, this really includes most autoimmune inflammatory arthropathies, seronegative spondyloarthropathies, Reiter's arthritis, psoriatic arthritis. They all present relatively similarly for this pathology. In general, this is a relatively high-risk population for surgery overall. That's both because of the concomitant medical issues that they tend to have, the medications that they have to be on around surgery, and their bone quality. So these patients are at much higher risk of fracture during and after surgery because their bone is just terrible around where we put the implants. The other thing that makes them high risk are the medications that we know give them such a better quality of life, but that do increase their risk of one of the most devastating and feared complications of joint replacement, which is infection. Now, just this year, the American College of Rheumatology and the American Association of Hip and Knee Surgeons got together and produced a really good detailed guideline on medication management around hip and knee replacement. And this is really helpful for all of us as clinicians, but it's also helpful for patients because what this really showed in the literature is that many of these medications you can continue throughout surgery without increased risk. The biologics, all of the TNF-alpha inhibitors, the monoclonal antibodies, those you do have to stop for a relatively short time period and then continue. But this guideline, which is publicly available, gives us a lot of good guidance on how to stop those medications, which medications to stop for those of you who manage these diseases without the aid of a rheumatologist. And with stopping those medications for a short period of time, we can make the surgery much safer in terms of perioperative risk of infection. Now, restarting those medications for the long term does increase these patients' risk of infection a little bit overall. However, the quality of life difference for someone with a bad inflammatory disease, the surgery still generally outweighs the risk of complications, including infection. Trauma, again, we're seeing a lot more prevalent, particularly with hip fractures. So this would just be an example of an extreme one where this patient had an acetabular fracture and a lot of hardware. This patient would be a much more common example where they had a hip fracture and a blade plate. We see a lot, as with the increasing prevalence of hip fractures, we will see more of this. We do a lot of joint replacements for these patients, but this surgery is not quite like a regular standard run-of-the-mill joint replacement for osteoarthritis. It has a much higher complication rate overall and a much longer recovery rate. So it's important for us to counsel our patients and expect that. And that's because we have to take out the hardware. They tend to be patients who have issues already because they were frail enough to fall and have a hip fracture or they got into a big motor vehicle accident. So these are a little bit different than your run-of-the-mill joint replacement, but we do a lot of them. And then osteonecrosis. So osteonecrosis is a disease that we don't fully understand, but it's essentially a disease of microvascular blood vessels. So the hip is the joint most commonly affected, and that's because its blood supply, quite frankly, just stinks. The profunda femoris comes off of the iliac and divides into the medial and lateral circumflex vessels which surround the hip, and then they come up into these little retinacular vessels which are very, very tiny. And the blood supply this portion of the femoral head is particularly at risk for anything that would disrupt it. And we don't quite understand why some of the things that seem to disrupt it do, but by far and away the most common risk factor is chronic steroid use. So people have to be on a lot of steroids for asthma, patients with lupus. And sometimes we see a lot of patients with inflammatory arthritis who are on a lot of steroids develop this in addition to their inflammatory arthritis. Also, in particular, for our area of the country, is both HIV and the medications that are used to treat it. Both of those things can cause osteonecrosis, and alcohol abuse. Those are the three most common things. Now, there's other bunch of rare things that can cause it, like I don't know, deep sea diving is not all that common around here, so I wouldn't worry about it so much. But it presents, this presents differently than osteoarthritis. And the reason for that is this, you can think of this as essentially like fractures of the hip on a subchondral level. So what'll happen is the bone here beneath the chondral surface will die and it will fracture, and that really, really hurts. So unlike arthritis, which is sort of a slow, steady progression, this can be all of a sudden my hip really, really hurts. And initially on x-rays, you won't see anything. But if someone has a lot of hip pain that you really think is coming from the hip and the x-rays are negative, that's when it's worth getting an MRI. And the reason for that is before this collapse happens, if we can catch the osteonecrosis, sometimes we can do an operation called a core decompression, and we can change the course of the disease and hopefully prevent it from progressing. Once the bone has collapsed and the femoral head is no longer around, your only surgical option is a hip replacement. And universally, almost all of these patients end up needing a hip replacement because this disease is so much more painful than arthritis. The hip replacements themselves, in general, are no much more risky than a regular hip replacement in this patient population, absent of the reason for the osteonecrosis. Other joints can present with osteonecrosis, the shoulder and the knee. Now, the knee, those are more rare. The knee in particular is rare, but definitely holds probably the best acronym in medicine. It's called spontaneous osteonecrosis of the knee, or SPONK. I'm sure they came up with that one intentionally. Now, spontaneous osteonecrosis of the knees can often be an incidental finding. So unlike osteonecrosis of the hip, which we almost never see incidentally, we almost always see it when it causes pain. Sometimes we'll get an MRI of the knee and there will be a little area that will have some osteonecrosis, or what we think is osteonecrosis, and that may not actually be causing pain. So in the knee, it's not necessarily a disease that is going to need surgical treatment or going to warrant surgical treatment. It's often a disease that we can just sort of watch and may never cause symptoms. So it's a little bit different in the knee, and we really don't understand why it happens in the knee as much. So childhood hip disease is developmental hip dysplasia. Now in this country, a lot of this is caught early now. We put kids in Pavlov harnesses and we change the course of this disease, but the more subtle parts of this disease, which comes in a spectrum, are not caught early. And so for some patients who have an abnormal articulation between their acetabulum and their femoral head, this can lead to early arthritis. So for instance, this patient who's I think in her 20s, she has developmental dysplasia, and you can see that this hip is definitely not normal, but because it didn't hurt until she was in her 20s, we didn't catch it as a child. On the other hand, this patient who has the sort of most severe form of dysplasia, where her hip was born dislocated and she created a new hip joint up in her pelvis, she would obviously present much sooner. Now, often we'll end up doing surgery for these patients much earlier than we would do otherwise, although these patients will surprise you. For instance, there's a whole body of literature on patients like this who have congenital dislocations and no pain, and actually live without surgery, which is always a good thing. So when you refer someone to an arthroplasty surgeon, when you talk about an arthroplasty surgeon and joint replacement surgeon, in general, these are the surgeries we perform. We perform hip and knee replacement and partial knee replacements. Most joint replacement surgeons nowadays really are not generalists anymore. We're going increasingly subspecialized, particularly in large major metropolitan areas. So most joint replacement surgeons now don't do arthroscopic surgery. We tend to refer them to our sports colleagues. So I think that's just important to know when a patient has expectations of sort of going to a surgeon, that they may be shunted to or referred to another surgeon depending on their diagnosis. So if they have arthritis, then that's the best reason to send them to us. If they don't have arthritis yet, or they may not have that much arthritis, then it's maybe reasonable to send them to a sports colleague first. So arthroplasty literally means replace the joint, or joint reconstruction. And it's a replacement of a diseased joint surface with some kind of prosthesis. And over the years, there have been many, many types of prostheses investigated to try and find the best one. These include a whole variety of metal and plastic and ceramic surfaces. So in general, this is an extremely high impact intervention. All of the studies on quality of life show that both hip and knee replacement confer a significant improvement in patients' quality of life. Hip replacements more so, but knee replacements as well. And it turns out this is an extremely cost-effective intervention. This surgery, I think, was called the surgery of the century last century. I hope it still stays the surgery of the century this century, but that's because it really does relieve pain, restore function, and is quite cost-effective for society. So for a total hip arthroplasty, it's essentially made up of 4 components. There's a socket, which replaces the acetabular cup, and that's usually in this country made of titanium. There's a liner that goes in the socket, which in this country is usually made of what's called highly cross-linked polyethylene, which is essentially just a really, really hard and wear-resistant plastic. We've also, over the years, played with different surfaces there in terms of either ceramic or metal. Now, the metal as a surface, as a bearing surface, has really gone out of favor in the last 10 years as there is a higher rate of complications from a metal-on-metal surface that cause a higher revision rate. So most surgeons nowadays will not use a metal-on-metal surface. Some surgeons still use a ceramic-on-ceramic surface for very young patients, although by and large now the most common combination is a polyethylene and ceramic, or a polyethylene and metal. And those both give really good wear rates. Now back in about the turn of the century, we started using this highly cross-linked polyethylene, which represented sort of an astronomical leap in how quickly the joint wears out. And that's really what's allowed us to give younger patients surgery and be able to tell patients that they can have longer expectations of their joints, and we'll go into that a little bit. So this is what it looks like. In general, so there's a cup, which is made of titanium, there's a shell, or there's a liner which is made of plastic, there's a head which is either metal or ceramic, and then there's a stem which is titanium. And this surface here and the surface on the back of the shell the bone grows into that. So most hip replacements in the United States are what we call cementless, meaning we don't use bone cement to cement them in. Now sometimes we do if the patient is particularly osteoporotic or osteopenic, and that actually has just as good outcomes as the cementless. The reason that we do cementless in the United States versus cemented, which Europe does more often, is largely historical. It's just a fun historical fact that the FDA wouldn't approve bone cement for like 20 years in the United States, so people developed these cementless implants. And so this is what it looks like once it's put in place. So this is AP pelvis. You have an acetabular shell, you have a femoral stem, and a head and the liner. And it generally restores the biomechanics of the hip joint. Now for hips, this actually works really, really well because it's a ball and socket joint, and we're giving them a ball and socket joint back. For knee replacement, it's a little bit different. We divide the knee into 3 compartments: the medial, the lateral, and the patellofemoral compartments. And we replace either all 3 compartments or single compartments. For the knee, in general, the femoral component is almost always cobalt chrome or cobalt chrome alloy, which has nickel in it, which has some relevance. The tibial component is either titanium or cobalt chrome. The liner is generally polyethylene. And then we often replace the cartilage surface underneath the patella, which is also polyethylene, that's sort of hard plastic. For knees, these are almost always cemented in the United States. So we do use bone cement for these. And that's because the knee longevity without bone cement didn't seem to be as good. And this is what it looks like. So you have a femoral component here that goes on the end of the femur like this. You have a tibial component that goes down to the tibia. This is the liner. And then this is the button on the back of the knee. Usually with knee replacements, we will take out the ACL and often take out the PCL as well, but we retain the MCL and the LCL. The design of the implant with this little post here, and some of them don't have posts, but the design of the implant tends to sort of restore what we think of as the best function of the ACL and the PCL. But importantly, this is not a ball and socket joint, it's not a simple joint. So the knee joint itself is not replacing exactly the type of joint that we're taking out, which is one of the reasons that we don't think knees do quite as well as hips overall, although they still do very well. It's also one of the reasons I tell that patients who have hip replacement can often forget that they have a hip replacement, but patients who have knee replacements kind of always know they have a knee replacement. It's still a very good operation, but managing patients' expectations around this is important, and that's largely due to the constraints of the joint itself. So this is what it looks like when we do the surgery. I think a misconception patients often have is that we lop off the end of the femur and lop off the end of the tibia and sort of give them this new knee, but it's really a resurfacing. So what we do is we take about a centimeter of bone away from the entire edge of the femur and a centimeter of bone away off the top of the tibia, and we replace it with the metal and the plastic, and this is kind of what it looks like afterwards on an x-ray. So it's not that you're taking away the whole knee, it's that you're resurfacing the knee. And then what we can also do are partial knee replacements. And these work really well in the right patient. So this is where we're replacing just the medial compartment or just the lateral compartment. And we will also just replace the patellofemoral compartment in the right patient. Now, these do, for the right patient, do extremely well. These feel like a more normal knee. We're not taking away the ligaments. The downside to these is that if they develop arthritis later on in the other compartments, we may need to go back and do more surgery. And if you don't have kind of strict indications about this, if they already have arthritis or if their ligaments are damaged, then this isn't going to work very well, and they end up needing more surgery later. And that's important for us to know and also for patients to understand, because if they need what we call conversion from this, the results are not as good as if they got the total knee in the first place. And then we also do a lot of revision surgery. So knees can fail and hips can fail. Knees fail because of infection. They can become loose from the bone. The bones around them can fracture, which we call a periprosthetic fracture, or they can become unstable. And this is largely symptomatic. So, and we revise knees for any one of these complications. Now, the overall revision rate for a knee for the lifetime of the implant for any one of these complications is somewhere around 1% to 2%, so it's not high. But usually when things go wrong with these, it does mean surgery, and these surgeries are significant surgeries, and they never function quite as well the second time around as they did the first time around, particularly for infection. Infection is the dreaded complication for all joint replacement surgeons, because what happens is the bacteria hangs out on the metal and reproduces and forms this biofilm we call a glycocalyx. And that biofilm is really, really hard for antibiotics to penetrate, which means that often, in order to get rid of the infection, we have to take the knee out, leave the patient without a knee or with kind of a fake knee while we treat them with IV antibiotics for a couple months, and then come back later and reimplant the knee. So it's extremely morbid for patients. It's very depressing. It's really hard to go through. Now, often we can do that with a good measure of success. So we have that's called a two-stage exchange. We have about a 90% success rate with that. But unfortunately, the knee that we put in often doesn't function quite as well. So it's paramount that we try and catch these early, that we try and prevent infection, and that we try and make sure that the patients are helping us prevent infection by reducing their risks. Now for hips, it's essentially the same thing. They can become infected, they can become loose, they can fracture, or they can dislocate. Again, around the same average complication rate for any one of these complications, around 1% to 2%, but again, for any one of these complications, it often means surgery. So some of the changes that arthroplasty have gone through in the last decade are fairly significant. And one is the longevity. So it used to be that people were too young for arthroplasty, even if they were in their 60s. Nowadays, it really boils down to a quality of life decision. Some of this is very surgeon dependent. Some surgeons are still very hesitant to operate on people in their 40s, certainly on people in their 30s, and we certainly try and push it off as long as we can. But the balance of quality of life with the expected longevity of the implant now is a much different decision. And so we're doing arthroplasty in patients now much more routinely in their 50s and late 40s, and occasionally in their 30s, and sometimes if they have really bad problems in their 20s. Now, if we're doing them for them in their 20s and 30s and 40s, we still counsel them that they're probably going to need another surgery down the road. But with the newer implants and the newer designs and that new plastic, we were hoping to get 20 plus years out of the implant, whereas we used to tell patients it was really 10 plus. And the other big part of this is that, in order to counsel patients, I tell them that on average is about a 1% failure rate per year for any given reason for all comers, meaning that At about 10 years, maybe about 10% of them need to be replaced for some reason. At about 20 years, it's about 20%. Now that's a little bit overestimating, but it's an easier way to counsel patients so they can be involved in shared decision making. Now with doing arthroplasty for younger patients comes a pretty dramatic change in expectations, as well as the fact that many of our older patients are staying active longer. And this is hard to counsel patients on because there really isn't much literature to guide us on what patients can and can't do with their joint replacements. I have patients who ski on their joint replacements. I have patients who run marathons on their joint replacements. I think it's nuts, but they do it. And we don't have any literature to guide us. So that's going to be very surgeon dependent. What the patient can or can't do with their joint replacement is often largely up to the patient, but we will advise them in general to kind of not do a ton of high impact things. So I don't think it's wise to run a marathon on your joint replacement, but if you want to jog every once in a while on it, I think that's pretty reasonable. And this guy has a knee replacement. Now, granted, he's like a former Italian national champion water skier, but people are doing things with these joints they didn't used to do. So, time will tell whether or not those things are actually okay for them. The other big change in arthroplasty is the safety of arthroplasty. So with modern anesthesia, our pain management protocols, and our sort of enhanced recovery protocols, and what we're discovering about older patients, we don't tend to tell people that they're too old for arthroplasty anymore either. When you look at the literature here, the age-adjusted mortality within 1 year for patients is no different for 80-year-olds or 90-year-olds. Now, they do have a slightly increased risk of certain complications, but not so much so that we wouldn't do it. And those risks tend to be largely related to their comorbidities and more to their frailty. So in general, the literature supports that no one's really too old for arthroplasty. It has a lot more to do with how sick they are and how frail they are. So I definitely see a number of patients in my clinic who are in their 60s, who are 60 going on 110, who I will counsel not to have a joint replacement. But I have done a number of joint replacements now for patients in their early 90s, and they're doing okay. And this guy, I think he died a couple years ago at 94, but at 92, got his knee replaced and continued doing his Masters Championship rowing. I think it's pretty cool. Another huge change in arthroplasty, and this is probably, I would argue, one of the most significant changes in the last decade, is the change in the pain management around the surgery. So it used to be you'd stay in the hospital for days on end, it'd be extremely painful, but we've really changed how we approach that. And we use now a multimodal, very non-opiate-based regimen. So almost all patients get a spinal anesthetic. Most of them will get some kind of regional nerve block or a regional nerve catheter, and then we start them on around-the-clock non-narcotic medications. We actually start these the morning of surgery because there's really good evidence that sort of preempting the pain fibers actually has a large benefit. And then we give them around reasonable doses of these medications around the clock, Tylenol, some kind of anti-inflammatory, or the Celebrex or meloxicam, and either gabapentin or Lyrica, throughout their whole hospital stay and often into the first couple of weeks. And by doing that, we really get to minimize the number of opiates that they take. These patients now need very few opiates compared to what they used to need, and they get off them a lot sooner. So for most total hip replacement patients who are not on opiates to begin with, we can get them off of opiates within a week or two. And I definitely have patients who tell me that they took 1 or 2 pills and that was it, and then they just went right to Tylenol. For knee patients, it's a little bit longer, but we can often get them off the opiates a lot quicker as well. And this has been a huge change for us and really, really helpful for patients. And it changes their expectations as well. And I think a huge part of this change has been telling them that we're going to do this and they're not going to need the opiates so that they don't think that they need the opiates and then they end up not needing the opiates, which I think is a really important part of all of us managing our opioid crisis. And I think surgeons are acutely aware of the role that we play in both contributing to this epidemic as well as trying to manage it. And I'll talk a little bit about sort of risk reduction later. Another really significant change in the last 10 years in arthroplasty, and even really the last 5 years, has been how we manage thromboembolism prophylaxis. Now, a long time ago, when the CHEST guidelines originally came out, every single member of that guideline was on the board of the companies that made the medications. And that led to sort of a lack of research in this area for a really long time, I think. Nowadays, the literature strongly supports that for most patients who are not higher risk, we can use an aspirin-based protocol for DVT prophylaxis. And so this is what we're using at UCSF, and most of the major academic centers have gone to aspirin BID dosing for about 4 weeks after surgery. This has been shown for a risk-stratified population, no increased risk of DVT or PE, has actually been shown to have a decreased risk of wound complications, a decreased risk of infection and bleeding events. There's no more need for injections, which patients hate, and monitoring, which we all hate. And there's a significantly lower risk of needing a blood transfusion. Now, concomitant to the aspirin change has been a use of tranexamic acid around surgery, which has also dramatically decreased the risk of needing a blood transfusion. So for a primary total joint replacement in the last year, of the 250 patients I've done primary total joints on last year, I've transfused 1 patient. So people really don't need blood transfusions anymore, and we don't have them donate their blood anymore or anything like that. That is long past. And part of this prophylaxis change, again, is a change in expectations in how we do the surgery. So people get spinal anesthetic, which lowers their risk. They get up and walk the same day of surgery, which lowers their risk. And they all get SCDs, which does seem to lower the risk. People don't get TED hose anymore because it causes more problems than it solves. Now, we do use a risk-stratified protocol. So for certain patients who are higher risk, we will put them on Lovenox or warfarin or a 10A inhibitor, depending on their risk. Or if they need to be on one of those before surgery, we'll restart it after surgery as their DVT prophylaxis as well. The guidelines from the AAOS, American Academy of Orthopedic Surgeons, in 2011 supports this type of protocol and is more in line with the more recent chest guidelines. So I think this is really, most practitioners are moving towards this protocol, which is, I think, a dramatic improvement for patients. The other really significant improvement, and this is really kind of over the last 2 or 3 years, is the recovery from this. So for many patients, we are moving this surgery to outpatient. So we're doing a lot of hip replacements now outpatient. We're going to start doing more and more knee replacements outpatient for the right patients. Now, again, we sort of risk stratify those patients who we think can be outpatient, but it's been pretty successful. Additionally, you're going to start to see more of this as Medicare this year they didn't used to allow this, and as of January 1st, they're going to allow us to do joint replacements outpatient. For patients who are inpatient, they stay in the hospital on average 1 night. And even for UCSF, where we take care of a complex sick population, our average length of stay for a primary joint replacement is 1.2 days. So most patients go home the day after surgery. And most of them go home. Very few patients nowadays need a skilled nursing facility or rehab facility. Part of that has to do with how we're paying for these and sort of the rise of alternative payment models and bundled care and the shunting of these patients away from that and the closing of skilled nursing facilities and rehab centers. But as that happened, a body of literature started to develop that showed that the patients who went to skilled nursing facilities and rehab facilities often had higher complication rates, even comorbidity and age adjusted. And that's because when they go home, they tend to do their own rehab. Right? They're getting up to get themselves water. They're getting up to go to the bathroom. They're in their own environment. They're getting better sleep hygiene. They're in a place with a far lower burden of bacterial disease. So they do better at home, and they're actually lower at risk if they can go home. So we tend to send most of them home now. And you'll see a lot of buzz around this called sort of enhanced recovery after surgery. But this is really about protocolizing all the episodes of care so that the patients know what to expect going in. They get a really good sort of model of care, and then they have a low complication rate coming out and really good follow-up. And for us, this is kind of what it looks like. They come in, they get their preoperative visit, they get assessed for surgery. If they decide that they want to have surgery and they're a good candidate, we have a nurse navigator who navigates them through the process. They take a preoperative class, which guides them through what to expect. They then have a preoperative anesthesia visit to assess any anesthesia risks. They come in for surgery. They're seen by physical therapy and start walking the same day of surgery. They have a surgery assessment by PT and OT that says whether or not they can go home with home health therapy or actually do need to go to a rehab facility, and then often they get out on post-op day one, and then they come back and see us. Throughout all of this now, we're communicating them via an iPhone app. The protocols around this have changed dramatically, and this has really allowed us to manage our patients throughout surgery, make their recovery much, much easier than it used to be. And I think an important part of this too is we have really started to adopt a lot of risk reduction. And I think you're going to see more and more of this as, again, bundle payment care plans tend to come to the fore as the primary method for paying for these. This is very surgeon dependent, but in general, and this is our protocol at UCSF, the literature supports that if your diabetes isn't under reasonable control, you have a much higher risk of infection and it's not worth having surgery. So we won't do someone's surgery until their hemoglobin A1C is under 8. Now may not be the best proxy for their diabetic control, but it's kind of the best one we have. A recent study just looked at fructosamine as a measure, so you may start to see that being ordered. But in general, we need their diabetes to be under control. We also will not allow them to smoke or use nicotine, and we do test them. There's an increasing body of evidence that shows that this increases their risk of infection and the risk of clotting. We don't quite know if having them quit smoking and quit nicotine decreases that risk yet, and it's not a randomized control trial, it's sort of a multi-arm trial going on now that will hopefully answer that question. But nicotine is a strong vasoconstrictor, so it makes logical sense that if your blood vessels are constricted where you're trying to heal from surgery, you're going to have a bad time. And so we will make our patients quit smoking before surgery. We also will not operate on patients who have a BMI over 40. There's really good evidence that shows that the risks increase with every single level of BMI that you go up over 30. They start to get dramatically higher when you hit 40. And if you look at sort of a receiver operator curve or a Uden's coefficient, that tends to be where the inflection point is about sort of, sensitivity and specificity for risk. So 40 tends to be where most people put their cutoff. Some surgeons will actually lower that cutoff to 35 if they have some other risk factor. But in general, this is one thing we won't do surgery for, is if patients have a BMI over 40. And it is one of the things, both smoking and obesity, this is one of the places where we can actually intervene and institute behavior change. So I think it's a really important thing for surgeons to kind of hold firm on. Another place where we're trying to risk reduce is with chronic pain. So for patients who are on opiates, they have a higher complication rate, longer hospital stays, higher readmission rate. There's a study that came out last year that showed that for patients who were asked to decrease their opioid dosing by 50%, they lowered their complication rate. So we are now asking for patients who are on significant amounts of chronic opioids that they need to actually cut their dose in half before we'll do surgery. And that's been challenging for patients to do and been challenging for us to do, but the patients who are able to do it, I think we're seeing a real difference. And I'm not talking about a patient who's on the occasional Norco, occasional Vicodin, or, one Vicodin a day or something. I'm talking about the patient who's on, daily Dilaudid or, 20 milligrams of morphine, that kind of stuff. And then substance abuse. So extremely high risk population, alcoholics and IV drug users. So we have a 1-year sobriety period that we won't operate if it's not documented. And again, all this is about, it's really in the best interest of the patient, and we try and frame it that way for them. Some of them get very angry and upset with us about this, but I think it's really our duty to do this. So I think at least within our practice, you'll see us holding firm on these policies. So I want to go a little over some of the myths or some of the questions that you'll probably get from your patients, and I get from my patients all the time. And one question is sort of platelet-rich plasma and stem cells for arthritis. I know Dr. Lansdowne has talked about this, and there's been a lot of sort of buzz about this. For patients who already have arthritis, in my mind, the literature does not support either of these treatments in terms of the cost benefit, particularly because they're not covered by insurance, they're cash pay. So this is just some website. If you Google stem cell therapy, you get a million websites. This guy is charging $5,000 per injection, which is actually about the average of stem cells. But good news, he offers financing. My personal bias about this is I consider this unethical, that we're charging patients money for unproven treatments. I'm waiting for a good proven treatment that's FDA approved and covered by insurance, and so I tell my patients that this really is just not worth it. And I had a patient this year who spent $30,000 on stem cell treatments. This is a retired patient on a fixed income, and she spent her retirement savings on this before I replaced her joint. And she had bone-on-bone arthritis to begin with. And so I consider whoever did that for her to be pretty unethical. Another question we often get is, will my body reject the joint? Will I have a metal allergy? In general, this doesn't happen. These are very biologically inert materials, and of the millions of these that we put in, we really don't see any sort of rejection or allergy. Now, for patients who have a really severe allergy to nickel, sometimes we think that they may have a reaction to the knee replacement, and we have some options that are non-nickel based or sort of ceramicized that we can use in those patients. But the science isn't actually clear about whether or not that is the reaction, and so sometimes even in those patients, we think they might be having an allergic reaction, but we honestly have no idea. There's some tests that we use to try and determine that, but those tests aren't that great either. In general, though, this doesn't really happen. They don't reject the joint. Gender-specific implants is another big one that we get a lot. People's bones are not quite as gender-specific as people would like them to believe in terms of their joints. They're more size-specific. And the size of these implants come in several millimeter increments. People tried to design a gender-specific knee a number of years ago from a number of different companies. It was just a smaller knee for women. It's all it really was. And the studies show that it didn't make any difference. Minimally invasive surgery is another kind of buzzword that you'll hear a lot about with arthroplasty. And there's a ton of marketing that goes into this from surgeons because surgeons want the business. There is no minimally invasive arthroplasty. You can't fit those implants in without making a decent sized incision. The average incision is somewhere between 10 to 14 centimeters for a hip and somewhere between 12 and 16 centimeters for a knee. And many, many studies have shown that there's no correlation with the incision size and the outcome of the replacement. And some studies have actually suggested that the smaller incisions have a larger range of implants put in the wrong way because you can't see what you're doing, and that actually causes a higher failure rate. But people will market this, but this doesn't exist for joint replacement. And then navigation, robotics, and computer assisted. There's a lot of different companies that are looking at this and a lot of different tools. I've used a number of them throughout my training and some in practice. For some patients, this is necessary who have severe deformity, but in general, the technology is not there for it to make a significant difference. In the randomized controlled trials for all of these technologies, not a single one of them has shown a clinical difference yet. So it's a valid way to do the surgery, but it's not going to make their outcome any better than if the person who is a good joint replacement surgeon who didn't use it. Yeah. So I just want to talk a little bit about when bad things happen, and I want to just make this really simple, is that in general, there's a low complication rate, but bad things do happen, and they can be absolutely devastating for the patients and require more surgery. Some of them are easier to fix if they're diagnosed early, particularly infection and loosening. So if your patient has any new mechanical symptoms of their joint, any new pain in their joint, or just pain that won't go away, just send them right back to us. Just have them see some joint replacement surgeon. It's not really worth going through the rigmarole of, is this muscle soreness, all that kind of stuff. I would much rather see my patient back, take an x-ray, make sure it's not something that I need to address quickly to prevent a larger problem. So just send them back to us, and every joint replacement surgeon should be perfectly happy to see those patients who are having any sort of issues with their joint. Because again, if there are certain problems, if we catch early, we can have a lot better chance of fixing. So thank you very much. Happy to take any questions.